Dear doctors, welcome to Essentials of Acute Emergency and Critical Care. I am Dr. Sunil Garg and today I will be discussing arterial blood gas part 2 where I discuss an interesting case. Let's start today's case. 72-year-old woman with severe COPD presented to emergency department and shifted to intensive care unit on non-invasive ventilation. She was intubated and mechanically ventilated in the intensive care unit due to worsening condition. Here we can see two arterial blood gas reports. One was done in the emergency department on presentation as baseline and second blood gas was taken 24 hours on invasive mechanical ventilation. You can see in the current ABG or the second ABG, pH is 7.53 means alkalotic, while CO2 is 44 means within normal range. In this situation, the primary abnormality is metabolic alkalosis. Since pH is 7.53 which is alkalotic and bicarbonate is 38 which is on the higher side, so it means the primary abnormality is metabolic alkalosis. In critical care setting, the most common cause of metabolic alkalosis are prolonged use of diuretics on continuous nasogastric aspiration or persistent vomiting. Why does this patient have metabolic alkalosis if there is no such vomiting or diuretic use history or current use? How ABG of COPD patient will look like? Now look at first ABG on presentation, which was the baseline ABG prior to ventilation. Here you can see pH is 7.18, CO2 92 mm of mercury and bicarbonate 42 milliculant. This patient previously had chronic hypercapnia as evident by high CO2 and high bicarbonate value leading to chronic respiratory acidosis with metabolic compensation due to underlying COPD. Definitively, this patient also has component of acute exacerbation, that is the reason pH is low of 7.18. In chronic respiratory acidosis, kidney retain bicarbonate to compensate for respiratory acidosis. In chronic respiratory acidosis, bicarbonate increases 4 milliculant per liter for every 10 mm of mercury rise in CO2 value. So what happened to this patient? Why pH changed so dramatically from 7.18 to 7.53? When she was placed on ventilation, it corrected CO2 rapidly, leading to metabolic alkalosis. As carbon dioxide or CO2 is corrected, kidney cannot immediately excrete retained bicarbonate. So bicarbonate remains elevated and she develops alkalosis. This is called post-hypercapnic metabolic alkalosis. Means you remove the CO2 or you reduce the CO2, then the high bicarbonate or the metabolic alkalosis is unmasked. Why is this important? This entity is important because severe alkalosis can cause arrhythmias, seizure, hypokalemia, difficulty in weaning from ventilator, and reduced respiratory drive. So once you appreciate the condition, then you can correlate your patient's clinical condition with this arterial blood gas finding. What are the management principles of this condition? Avoid over CO2 correction or the rapid CO2 correction in those patients who has CO2 or chronic CO2 retention. Correct chloride and potassium depletion if it is present. Consider acetazolamide in selected patients and treat volume depletion if it is present in the patient. Remember, chronic CO2 retainers have renal bicarbonate retention. So, rapid normalization of CO2 can unmask severe alkalosis. Therefore, to diagnose this entity, always compare current ABG with previous gases. Dear doctors, this is the end of today's video. I hope this was a learning for trainee doctors. I see you in next video with another interesting case. Till then, bye and take care. If you have any question, you can ask me by writing in comment section.